Thanks so much, everyone, for racing back after lunch. I'm going to start the session and just talk slowly so other people can still join, so no one's going to miss out on the key speakers. But I want to start first with an acknowledgement of the Aboriginal and Torres Strait Islander owners of the lands that we're on today, which is the Wurundjeri people of the Kulin Nation. And I'd like to pay my deep respects to the Aboriginal and Torres Strait Islander elders past, present and future, and particularly any Aboriginal and Torres Strait Islanders who might be with us today, and any other First Nations people who've travelled to this World Health Summit. I'd like to make you especially welcome and give my deep thanks to the care that our lands have undergone. So it's a real pleasure to be opening this session, and I did want to give a big shout out to Rachel Huxley and Colin Bell, who have been instrumental in putting these sessions together. And for Deakin, it's a real pleasure to be able to invite hopefully some great discussion. It's a very tight time frame, but we'll try and invite some really good questions, and then I would really encourage you all to follow up afterwards with the speakers and with yourselves. At Deakin, we're really committed to building research with our community, our government and our industry partners that delivers the changes that we need to see to improve health and wellbeing for everyone. And one of the areas of focus for us has been obesity prevention, which we've developed with many of the regional partners who are at the World Health Summit and in the room today. Our strong focus on partnerships is really in recognition of the fact that to drive change, it requires deep collaboration with those who have the power to change the systems that affect our health and with those who are the end users of those systems. And I have to say, you're really lucky to have the three speakers that we have today. They're three of the most passionate researchers I know, and they have really honestly focused all their efforts on thinking about how to deliver prevention and healthcare differently to improve health and wellbeing, particularly for the most vulnerable in our communities. So we're really lucky to have them, and I thank all three of them for making time to come. I know you're going to really enjoy the work that they present. And in addition, I do ask you all to kind of take our collective responsibility quite seriously today. Globally, we're not seeing improvements in overweight and obesity. We know there's lots of great will, intent, practice and research, but we're not seeing enough implementation of the things that we know are required to improve child health, wellbeing and obesity. And I think that the opportunity of a World Health Summit is to forge new partnerships, to ask important questions and join the dots that need to be joined if we are actually going to have an impact on the health of future generations. So today we're asking for your insights on taking the next steps in these calls for action. And so we're going to set the scene for calls for action on community-based approaches, obesity in Australian health services and corporate determinants of health. And we really look forward to your participation in taking these calls for action forward. So without further ado, I'd like to introduce the first speaker. So the format is each of the speakers is going to speak for about 10 minutes and then we've got about 3 minutes for question and answer. So our first speaker is Professor Steve Allender. He's Professor of Public Health and Founding Director of the Global Centre for Preventive Health and Nutrition at Deakin, otherwise known as GLOBE, which is also a World Health Collaborating Centre on obesity prevention since 2003. Steve has an ongoing program of research solving complex problems with a focus on the burden of chronic disease and obesity prevention. He's held leadership roles on NHMRC partnership grants, centres of research excellence, and a number of grants across the international diaspora. So without further ado, thank you, Steve.
Thank you, thank you very much for your interest and for the opportunity to speak. I've set a timer here for 10 minutes, which should keep me fairly honest. I'd like to extend my acknowledgement of traditional custodians, particularly Wadawurrung people, which is where I spend a lot of my time. What I'm going to do is set a basic background for some of the work we've been doing over the last 20 years and then talk about a couple of the current projects and future directions that we're taking. So for this room, none of this is really news, but a lot of what we've been doing as a WHO collaborating centre and more broadly is multiple scientific trials across many communities. And so we've worked with probably more than 300 communities now. This slide's a bit old. Doing really high quality studies, intervention control, randomised control trials, cluster randomised trials, trying to understand how you improve the health of communities with a particular focus on kids. And what we've learnt in that time are the things we kind of already knew and for many people in the field is intuitive, but multiple strategies at multiple levels are critical. that ignoring the complexity is a mistake. We have to actually embrace it, and that local ownership and leadership is critical. So Professor such and such turning up in his specs and his coat and telling a community what the answer is a clear way to fail. But turning up and working together to learn how to deal with the complexity, use it as part of the response, has the potential to be successful. And I want to just talk about two of the trials that are most recent. One of those was in Western Victoria, and I think most people, I don't need to explain where Victoria is, but you're in Melbourne, which is in the middle there, so for those who aren't clear. So about 3.5, 4 hours drive west of here. We worked in 12 different communities across 6 municipalities in a step wedge cluster randomised trial. And the intervention there was to see whether or not we could make system science work to help communities understand the complexity of the drivers of child health and apply the best possible action at the right time to get the best possible answer. And the good news is the answer to that was probably yes. One of the biggest early changes that happened was the CEOs and leaders of the health services in the region all agreed to ban sugar-sweetened beverages from their health services as a direct result of the project. It started with one Western District Health Service and spread to all 13 across the region. First example of that happening in Victoria, and an amazing achievement. I can't claim any of it. I was in the room when I helped them see that sugar-sweetened beverages were an issue and helped them find potential solutions, and they chose banning sugar-sweetened beverages as the key thing to go. The policy exists, the implementation is probably another question. When we look across Who Stops as a complete trial, over 5 years intervention control cluster randomised trial, in the Who Stops communities, more than 500 different actions were initiated by members of the community, and that by community I mean leaders of health services, education, schools, but also lay community members. And nearly 2/3 of those related directly to food. So we gave them really evidence-informed decision-making support, and they chose food as a really key focus. You can see where we saw measured improvements in particularly health behaviours of kids, and we saw significant and ongoing changes in psychosocial wellbeing, mental health of kids, this is primary school age kids, and physical wellbeing of kids compared to controls. We also saw on average a 4% reduction in the number of kids living with unhealthy overweight and obesity. But I'll come back to that. It was non-significant primarily because of sample size. But just hold on to that idea that you saw a 4% drop. And Anna mentioned before the importance of partnerships. This involved pretty much all the branches of government you can think of, but also somewhere between 15 and 20 different community agencies. So if anyone's ever tried to do a multi-institution agreement for a partnership grant with 2 partners, you'll know what trying to do it with 30 partners feels like, and it's difficult. And one of the really fascinating pieces of work we did here was with the local water company. The taste of water was a major issue for water consumption and sugar-sweetened beverage consumption in this region. Based directly on this work, working with the water company, we developed a business case on the health impact of water for that region, and that led directly to a state investment of $26 million in improving the taste of water to improve the health of that community. So again, I can't claim this as a success of our group, but I can claim it as a success of helping communities see the complexity of the problem they're dealing with and thinking of ways to solve it. So this trial was very much, can we turn up and use system science and help communities work their way through it? And what we saw is huge churn in the number of people we might normally work with in any given community. So the next question we asked in a grant called Respond was, can we build the capacity of the existing workforce to do this work themselves without us having to be in the room? And that was called the Respond trial, which is an acronym which I can't remember, but if you're looking for it, that would be the way to find it. It's in the purple region here, which is in northeast Victoria, used to be called the Hume region. And again, we were working in 12 LGAs plus pilots in a number of communities. Same idea, can we build the capacity of the workforce to do the systems work for themselves instead of us turning up and running the session? So what we learnt in Who Stops, we were training into the Respond communities, and really in 3 parts. Using system science to understand and deal with the complexity, using very high quality opt-out monitoring to track the health and weight status of kids, and using modern system science to track why things were working or why things weren't. And I'll cut to the chase. So we trained more than 500 people around the region in systems thinking. And one of the things that happened halfway through was COVID, which most of us will recognise as a significant economic and social shock. For people working in the health sector in regional Victoria, it was an unmitigated disaster. Whatever job you were doing last week didn't exist for 2.5 years while you did contact tracing, and you know the story that went along with that. Despite COVID, Respond kids did better than control kids on basically all of the metrics that we assessed. And we don't know why, but we think because Respond existed before COVID hit, there was a level of resilience built up in the networks and relationships across that system that just didn't exist in other communities where the response was pure chaos. It was like, we have to do something, it has to happen tomorrow, drop everything. Respond communities were able to say, well, we've got some good things going, can we keep them going? Again, similar partners, but I also want to point out a lot of the science we present here and we do was subject of Magda's big national health check, which for those from overseas is an ABC documentary that was run. And probably a critical thing to see down the bottom, you might start seeing a pattern from Who Stops. We saw significant improvements in the mental health and wellbeing of Respond kids compared to controls. 8.5 points on a 100-point scale, doesn't sound like much. The variance in any particular scale is about 3 points. So it's a threefold improvement in the mental health relative to controls. And actually, sorry, it's protective. So the mental health of other kids went down, these kids stayed the same or went up. Same deal with physical wellbeing. This is on health-related quality of life scale. And the reduction in the number of kids living with overweight or obesity was about 6%. And I've provided the confidence intervals there for you to show you that the range, or the confidence interval, is somewhere between 14% drop and a 1% increase. This drives me insane because we're doing community-based trials where it is nearly impossible to get participants, and power is always a difficult problem. If you ask any government in the world, would you buy into something that on average will give you a 6% improvement? The answer would be yes. If you say to a journal reviewer, we think we've got something that works and it spans -14 to 1.8, the answer is no. So just be keen for you to hold on to that idea that the p-value says it doesn't work. I'd say I'd take 6.5% most days of the week. And what that's led to now is the training of local government staff right across the state, particularly in a partnership with Vic Health. And so we worked to help build systems thinking into the way local council municipal health and wellbeing planning was done. And that's an ongoing piece of work. And one of the key things we're really focusing on is what does the support system look like to constantly evolve a prevention workforce to be able to use the very best systems thinking so the right thing is done for the right community at the right time. And the community outside the door here and the community in Western Victoria are so very different that one size fits all is a guaranteed fail. I'll just point to some of the technology that we invented with the communities we worked with to help us do some of this work. Some people in the room will have seen Sticky. Don't panic. This is the most complicated diagram there is. But this is southwest Sydney, Campbelltown, 350,000 people, their leaders saying of all the things we need to think about when we think about child health, these are the key aspects. And one of the points I want to make is we can use this as a base logic model of the system to track change. And so I'll just show you, I think I'll show you, maybe I'll show you. I'll show you 3 months in, the same system in the middle, but the hollowed out boxes are the actions that are arising. So you can track in real time the changes you're making and the places they're landing on the system. And this is what it looked like at 2 years. So what I hope you can see through that sequence is we understand the base system we're trying to change. We can see where we fit. And more importantly, the bubbles here are actors in that system. So we know who's working with who, how they're working together, what actions they're delivering, and what part of the system it's landing on. This is pretty nascent and we're trying to work a lot of things out with it. The thing that surprised us, but I suppose is gratifying, is that people vote with their feet, and the validation of what we're doing is the ridiculous growth in the number of people who are using system science and the techniques we've evolved through these grants for all sorts of different problems. So this is by no means an exhaustive list, but it also gives a sense of just the range of places where we feel these techniques have been useful and we've been able to work with them. Thank you very much.
Thanks very much, Steve. We've got time for one or two questions. If you've got a question, just please come up to one of the microphones.
I'm happy to get the time back if you want.
No, it's all good. I've got questions if no one else does.
That's why I'm happy
the
to
mic.
get the time.
And just introduce yourself.
Hi, my name is Aki and I'm from CSIRO. Really great to hear your presentation. We've done a lot of research in the space and we're really interested in what Deakin's doing. My question, Stephen, is really about how you got those partnerships to work. There were a lot of partners there and a lot of local level initiatives. Could you give us some advice and maybe some of the anecdotes behind getting those things going? Thank you.
Yeah, it's obviously it's critical, but it's critical that the partnerships are really strong, and they're not always. So in all of those trials I've described, the partner came to us, we didn't go to them. So in each case it started with, we'd really like to do something to improve the health of our kids. We think child obesity is an issue, what do we do? We'd say we don't know, but we can help you find solutions. So that's really critical. When you have to roll that up into something NHMRC fundable that has randomised controlled trials, inevitably partners miss out and other partners are included that maybe didn't necessarily want to play. So we also learn a lot about the minimum capacity required to be able to succeed at that approach. It doesn't work everywhere and it requires a bunch of basic level skills. But in answer to your question, the partners would come to us first and then we would build a relationship. And the other thing, it looks like a piece of science and we knew what we were doing at the start. That's nonsense. I particularly have relationships with a lot of leaders in those communities where they'll call me the night before we run something and say, I don't think this is going to work, you have to change it. And it's evolved in that way. So I think that's important to recognise as well.
Thanks, Steve. One last question.
Is this on? Yeah, great. Thank you so much, Steve. I come from multiple lenses. So my name is Lana Formoso. I'm the Mayor of the City of Greater Dandenong, but I'm also a PE and health teacher in high school. And I obviously see this issue on a day-to-day basis, not only within my students, but obviously in my community. We are the least active community. We have in all of Australia, I might add. We have the highest amount of obesity, the highest amount of smokers, the highest amount of alcohol and gambling addiction. So yeah, we tick them all. So I just wanted to thank you for this, and I know that Vic Health is coming out to implement this program with us, so thank you. And I'm coming to you now as a community leader to say, please join us, please help us. We need all the help we can possibly get, and as a mother of two children as well, I'm incredibly passionate and concerned about these issues. So I will speak to you at the end of this, but thank you so much.
Yeah, thank you. I'll make one thing.
Thanks so much. That's fantastic. And I know Steve will be very happy to speak to you afterwards. And that was our first call to action. So thank you for that as well. Big thanks to Steve. And now I'd like to invite Professor Kylie Hesketh to the stage just to say big thank you to Kylie for stepping in at the last minute. So Rachel Laws, who co-directs this program, I've worked with her, was going to speak today but had a family tragedy this morning, so Kylie has stepped in at the last minute. Kylie is a behavioural scientist from Deakin's Institute for Physical Activity and Nutrition. She holds a Future Leader Fellowship from the Heart Foundation and leads a program of research that focuses on physical activity, sedentary behaviours and obesity prevention in children and youth with a focus on the early childhood period. She's been involved in policy and guideline development in Australia and internationally. Thank you, Kylie.
Thanks very much, Anna. I'll add my thanks and pay my respects to the Wurundjeri people whose land we're all on at the moment and on whose lands I live, work and play. So up here first is a photo of our current infant team. Infant has been going on since before 2008, so there have been many people involved, but this is our current team, and I'd like to point out in particular the third from the left there, which is the person you should be seeing standing up here at the moment, Rachel, and I will do my best to do her presentation justice. Furthest to the left, I would also like to make special acknowledgement to Karen Campbell. Her and I developed this program originally in 2008. So I guess start by talking about what is infant and how we've got to where we are. So infant is an infant feeding, active play and nutrition program. It's delivered via group sessions with parents at 3, 6, 9 and 12 months of age, with an anticipatory guidance lens around feeding, play and limiting sedentary time. So basically we're trying to upskill parents with the skills that they will need as their children are reaching the next developmental stage. So when their child is first trying to reach for the iPad, they've already got some skills and strategies in place there. The group sessions are supported by the My Baby Now mobile app, which provides evidence-based information for parents from birth to 18 months of age, reinforcing the key messages in our program. And we've found over many years of research and evaluation that parents find the information really useful to them. We know that children don't come along with a manual on how to parent, and so this program, which was originally designed for first-time parents but has extended out to all parents, they find really useful. Here you can see our infant key messages. So all of the program is designed around promoting these messages and how they apply at the different ages and stages. We did some contemporary branding, so the program was developed with parents and maternal child health nurses in the first stage, and then all of our branding has undergone evaluation by parents, and we find that particularly low SEP parents really resonated with this messaging that we have here. Sorry, I didn't realise there were click-throughs, so you missed that lovely little quote from one of our health professionals our professionals tell us that they like having these key messages that keep them to task and provide the right guidance for parents. So Infant has gone through these stages from being a program that we developed, as I said, with parents and maternal and child health nurse input, was tested through a randomised controlled trial between 2008-2010, was shown to be effective with sustained benefits, which I'll speak to in a moment. We then moved on to small-scale translation back when Victoria had some funding through the National Preventive Centre that was very short-lived, was run in 8 local government areas across Victoria, and we're now in a phase of statewide implementation with the Department of Health here in Victoria. Just speaking a little bit about the randomised control trial. So this showed that there were benefits for babies at the end of the trial, which was 18 months. Those benefits actually continued for 2.5, were assessed at 2.5 and 3.5 years beyond the end of the intervention, so when children were 3.5 and 5 years old. So this is quite unusual to see that parents participating in a program when their babies were between 3 and 18 months of age, we were still seeing benefits in the children in terms of their nutritional state and reduced TV time when the children were 3.5 years old and when they're just about to start school at 5 years old. So normally you would see a drop-off from interventions. And what we think is happening here is that because we're actually targeting parenting and giving parents the skills, that they're able to continue to use those skills as their children grow and develop. So the messaging is continuing on even though the program itself has finished. We've also looked at, and this has drawn on work that certainly Anna was involved in, and Gary, I believe, some health economics information which has showed that the sort of reductions in discretionary food and drink that we see from children whose parents have participated in the infant program, which equates to about 1.7, just over 1.5 serves per week at 5 years of age, actually has big might seem like a small change, but is a big return on investment. So infants are relatively low-cost intervention, costing around $42 per family, and the sort of benefits that you can see drawn out of this health economic modelling done at Deakin shows that a one-serve reduction in discretionary foods can prevent a whole lot of health problems later in life and leads to very substantial healthcare savings. Moving on to the current state that we're in with infants, so the statewide implementation and scale-up, which began in 2020. This was enabled through an NH&MRC partnership grant, as well as Department of Health funding here in Victoria to promote the implementation functions. So here on the slide you can see our two statewide implementation coordinators who are funded by the Victorian Department of Health, and the system that we're using to scale up infants. So looking at adoption, so far we've seen 43 of the 79 local government areas across Victoria currently implementing infant, so running the group sessions and offering the My Baby Now app to families, the practitioners themselves, so this can be maternal and child health nurses, health promotion officers, community dietitians, community health workers and others have been trained in delivering the program and have access to our resources, and we also have implemented support and policy integration with local services, whether that be maternal and child health or other community health services, and within the systems that these are operating at the local government level. I guess another area where infant is quite unique is that it has actually been embedded into policy at a number of levels. So a lot of our local government areas that are implementing infant have actually embedded the program into their local council health policies. Within Victoria, infant is named in a number of government documents endorsing the program as having benefits for families, also at the national level and the international level. So just recently there was a review undertaken in the US of 58 complementary feeding programs, of which infant was classified as one of those, and infant was endorsed as the strongest model to be implemented in the community out of those 58 programs. In terms of what the program offers to practitioners and health professionals, we run training, which is a self-paced program, about 6 to 8 hours in total over 6 weeks, as well as then access to our health resources. We've had over 1,000 health professionals trained to date here in Victoria and also elsewhere in Australia, and the evaluation of this training shows that it increases confidence of practitioners to discuss these sort of issues with families and leads to change in practice. So I also wanted to talk just a little bit about the resources for parents and how we've worked to move infant from beyond the original program it was developed for the RCT trial into working with communities to ensure that the program meets their needs. So we have these resources now working with Western Public Health Unit, have been translated into a number of different languages that are the top Victorian languages. We've created low literacy booklets, all of those have been translated now into other languages so that the program is more accessible to more families within our state. And the evaluation of the scale-up in Victoria is still ongoing. We're basically doing an evaluation of the efficacy at scale, because we know that can vary from what's done in a research project, and also the implementation, evaluating how that has gone using the RE-AIM framework. So the key lessons so far are that sustained partnerships between researchers and end users from the outset are really important for being able to scale up evidence-based programs. Leveraging and integrating into policies and established service delivery systems is vital. both for the implementation initially and for sustaining the programs in communities, and local level partnerships, management support and champions to support the program delivery are vital. So we're very lucky that we've got a lot of partners who really champion the program and are really invested in ensuring that it continues in their communities. And I guess importantly for us as university academics, that implementation support is critical, but it's not normally funded through research grants, which is where our partners come in and have helped to support all of that. A key dilemma we're dealing with at the moment, which is probably, a question to put out to all of you, is who owns the scale-up and ongoing service delivery? So we have helped implement that into the community, and I guess our wish is probably that communities will continue to run this without needing our ongoing support. But where does that actually sit in the scheme of things? And just acknowledging our partners and funding. Thank you.
Thanks so much, Kylie. We've got time for a couple of questions. Who's got a question for Kylie? Yes.
Thanks for that, Kylie. I'm Rob Kosh from Monash Health, South East Public Health Unit. A few quick questions.
Absolutely.
One of the outcomes was less TV time. Are we talking just TV or less screen time?
That was from the trial. So if you think back to 2008, when I didn't even have a smartphone, the measure we used was TV time. We're looking at in the new trial if that translates, but we're assuming that it will. At that time, really, TV was the main source of screen time for children. And certainly the messaging, we have changed the messaging to ensure that it is screen time more broadly.
Right. Great. Have you been able to establish causality on these outcomes, that they were actually as a result of the program, not just because committed parents already get involved in the program?
Well, the first, the data that I've presented, some of that early data was from a randomised control trial. So the fact that we had all the families wanted to do the program, we let half of them do it, we didn't let the other half do it. One of the, that doesn't always work in practice. So it shows that compared to families who didn't do it, we saw those benefits. And in terms of the causality, using TV as an example, we have looked at some of the pathways to get to those outcomes, and we showed that for TV viewing, almost all of the benefit that we could see was actually by giving parents knowledge. So you normally don't see that knowledge translates to behaviour change, and screen time is probably a little bit unique in that lots of parents in the program actually didn't even know that it wasn't advisable to, give your children screen time, and actually informing them plus giving them the strategies did lead to that change.
Great.
Thanks so much. I think we've got one more question.
One more?
No, sorry. Yeah, but feel free to follow up afterwards.
Hi Kylie, great presentation, thank you. Mel Chisholm from NEFU. Quick question, so quite a lot of LGAs have taken it up, which is amazing. I think you said 49 out of 79, is that right?
Yep.
What are some of the barriers, I guess, that you're hearing about in terms of take-up in some of the other LGAs?
Yeah, so one of the key barriers is, as we see in lots of fields, that kind of crowded curriculum, that they're being mandated to run other programs, for example, in the maternal and child health space, and they've also potentially had resourcing decreased post-COVID, that they don't have the resources, so that's often one barrier. Having said that, some of our communities are managing to see that by running the program, we actually see anecdotally nurses tell us that they have fewer ad hoc visits and appointments, so it kind of may have a little bit of a balancing effect there, but probably the biggest one is resourcing.
Thanks, Mel. We might have to hold your question, sorry, but definitely keep it in case we've got time at the end.
Yep.
Can you all join me in
everyone.
thanking Kylie for a great talk? And I'd like to now introduce Professor Gary Sachs. He's Professor of Public Health Policy and a co-director of the Deakin Global Obesity, not anymore, it's Global Centre for Preventive Health and Nutrition, GLOBE. His research focuses on policies for improving population diets and preventing obesity, including evaluation of government and corporate policies for improving the healthiness of the food supply. Gary's co-authored several international reports on obesity prevention, including the Lancet Commission on Obesity and several reports for the WHO and UNICEF. Thanks, Gary.
Thanks, Anna, and thanks for the opportunity to talk to everyone. The way we designed this session is Kylie spoke about actions sort of at the individual level. Steve spoke about communities. My talk is trying to get much more upstream than that, thinking about how we change the whole system. And I guess it picks up on a lot of what Michael Marmot was talking about this morning about neoliberalism. So just talking about big companies and what do we do about it. So I think we all know corporations have an enormous impact on health and equity. Obviously, things like tobacco, pollution, just the whole nature of the share market tends to concentrate wealth amongst rich people. And so specifically thinking about food, we also all know that our food systems are dominated by big business. I guess the point, what I wanted to kind of get across is that it doesn't have to be like that. This is a socially constructed thing. So it might feel inevitable that we have all these big companies that dominate our lives, but there are things that could be done about it if there was the political will to do so. So most of the health harms from businesses are really to do with the power of particular corporations. I've just put some random pictures there. But the Medici family, if you know 15th century Italian history, it was all about their power and how they influenced the whole economy. It's about, the harms are because corporations have taken power from the people. But there are ways we can address that. I've only got sort of 7 minutes, so I'm just going to flick through a whole lot of things just as food for thought, really. But again, if you know your history, Roosevelt in the 1930s had an agenda to kind of take back control for the people. The government in the US took a huge control over the economy. So I'll just talk through some things. And then I'll bring it back to unhealthy diets at the end. So we can disperse power. So at the moment it's concentrated with the corporations, but we can disperse that at the moment. In Australia there's an inquiry into supermarket power. In the US, Biden has appointed really strong anti-monopolists to the competition authority there. There are things that can be done to break up big corporates. Corporate political power can be addressed through laws around political donations. The NHMRC in Australia does, as an example, a tiny thing they're doing, but it's important. They've put really strong conflict of interest guidelines around the dietary guidelines. Those are the kind of things that help disperse power. International trade agreements, a lot of the trade agreements have provisions where companies can sue governments if the trade doesn't work out how they like. Recently, governments have been pulling out of those and changing those. I'm going through this really quickly, so you can chat to me afterwards about some of the stuff. We can democratize corporate decision-making. So in Scandinavia and Germany, there's laws about who's represented on corporate boards. Norway has gender parity rules. These kind of things just help balance power. There's rules in the EU about companies needing to take into account social causes, so not just have a profit motive, but legally be required to consider others. There's countries leading the way there. We have to see how it plays out. There's examples of governments taking control back. So there's a famous case in Bolivia of them taking over the water supply from a private company. I'm flicking through this quickly. Other stuff that could be happening is about strengthening countervailing power structures, so building others up, workers' rights, transparency, better reporting. Again, the EU has some really strong reporting standards, mandatory guidelines that companies, not mandatory standards that companies need to take into account, including human rights that they need to report on. increasingly shareholders taking some action in the food space. Unilever got pushed by shareholders to take action on healthy foods. They made a commitment to have, I think it's 80% of healthy food, but I think illustrating that shareholders can have a voice if they're organised. Scaling up other ways of doing business. There's examples from around the world of co-ops being funded in Spain. There's some really good examples of taking over food systems from the ground up. As sort of maybe a last resort after we've tried these things, you can dissolve some businesses. I'm not suggesting in the food space that we need to go there, but I just want to point out there are examples from the US of really harmful corporations getting dissolved by the government. Purdue Pharma, if you've followed that example, they were bad, got wound down. Leaded petrol is gone, yeah? So there's also potentially people write about changing the corporate form, so the limited liability where corporations are only up for a certain amount of damage they can do, that could change. It doesn't have to be like it is. In the food space, look, a lot of those, I did mention a couple of food examples there, but for the most part, the priority actions are around just regulating what companies do. So I think everyone in this room would know that there's a lot of action globally on food taxes, front of pack labelling, bans on marketing to kids, and that's increasing. More and more countries taking these sort of actions, which, while it doesn't get at the whole corporate form, it is about putting limits on neoliberalism. I could give a whole talk just on this slide. In Australia, we have looked at what the government is doing around food. That's a scorecard we produced a couple of years ago. Not much going on food promotion, and I think that's a key area of focus. Australia does pretty well in food labelling, but lots of areas within food where the government, the best practice is far ahead of where Australia is. The priority actions for Australia around obesity are restricting junk food ads, taxes on sugary drinks, improving food labelling. I think probably the audience knows those messages. Just in terms of tackling corporate power, there is a lot of action on corporate accountability. Several initiatives in place to monitor what food companies are doing. The Access to Nutrition initiative is probably the biggest one of those. Our group, as part of Informus, has done scorecards of companies. We've got a new report on supermarkets coming out next week. So an updated version of that 2018 scorecard of what actions companies are voluntarily taking. I think a really interesting space is that investors, big institutional investors, increasingly focused on nutrition, or at least saying they're focused on nutrition. So I mentioned the example of Unilever before. Tesco was also under similar sort of pressure from shareholders. Tesco ended up committing to have 65% of their sales from healthy food, which is in response to that shareholder action. More investors taking notice, and I think that's an interesting space. And so, look, I've gone through that really quickly, but my point, if you take something away from this, is that the world doesn't have to be like it is. And so there are tweaks that could be made to take power away from big corporates. There's some momentum for change. I mentioned the US having anti-monopolists appointed to the Trade Commission. I think they're focused on the tech sector, Facebook and the rest, but it shows a willingness to take on corporates. I think the focus on accountability, so grassroots organisations can really get behind a lot of these initiatives on accountability. And I think, I know this is a session on obesity and food, but the kind of things we're talking about, a focus on human rights, democratising corporates, applies across all of health. So I think a key space for collaboration. So hopefully that's given some food for thought around what we could do in this space. Thank you.
Thanks very much, Gary. You even finished 1 minute early, so now you've got 4 minutes for questions. So there's lots of time for questions. Just come up to the mic if you've got a question and introduce yourself. Tony.
Tony, hello, testing. Yeah, Tony Blakely, University of Melbourne. Thanks, Gary, that was great. I want to speak about food policy indices, Informus, and those types of monitoring mechanisms which are about the healthiness of food, how it's produced, or stuff like that. To my knowledge, that's normally done by a bunch of well-meaning academics, people like you and I. Do you have any examples internationally and any recommendations on whether it's a good idea to take that type of monitoring into a Department of Health and Ageing equivalent and make it part of a health survey monitoring, or into an independent commission or into a health promotion agency to just try and formalise it? Do you think that would be a net positive, or do you think that would lose the innovation?
Thanks, Tony. That's a great question. I think ultimately we want these monitoring and accountability systems to be part of the infrastructure of a country. So I think it does need to be owned by something more permanent than a bunch of academics getting funding for a study, absolutely. It feels like it needs to be owned by civil society, though. A lot of the time we're pointing the finger at government, and so it needs to be independent of government. But the exact mechanism for that, I'm not sure, and I think we need to work that out, because it can't just be, I apply for some funding for a study, I do it once, and then hopefully I get funding some other time to do it again. So yeah, great point, Tony.
And any philanthropists in the audience who would like to fund these things on a permanent basis, just talk to Gary afterwards. Any further questions for Gary? I've got one while people are thinking. I'm sure you had lots of examples that you didn't speak to, so if you had any other favourite ones, then let us know. But I wanted to know if you had an example of when you talk about stakeholder value, mandating stakeholder value. What does that mean?
So at the moment, corporations are legally constituted to look after the interests of shareholders. They need to take actions that are in the interests of shareholders. The idea would be to change that law to say that the corporations need to exist for the benefit of society, so they don't just need to take into account shareholders, they need to take account other things as well. The one example is Norway, that requires corporations to take into account human rights, at least. And they need to, there's proper metrics that they need to report on for that. So I think it's just moving from a shareholder view to a societal view of why the corporation exists.
Thanks. There's a question.
Hi, I was wondering if you thought that there was any sort of signal from what's just happening at the moment with the government putting some pressure on X to better control access to harmful content, whether that might signal that there might be a sort of building appetite to push back against major corporations and to hold them accountable for some of the harms that they're causing.
Yeah, I think certainly the tech sector has got a lot of attention for their role and the concentration of power amongst just a really small set of companies. And so, as I said, I think there's opportunity there to build on that, that kind of public willingness to take on those tech companies and expand that to other areas. So, I think I think we need to take whatever is going on and build on that. Yeah.
Great. Well, if there are no further questions, can you please join me in thanking our three fantastic speakers? And the next session isn't till 2:00, so please do come up and speak to the speakers if you would like to follow up. And as I said at the beginning, we do all want to work together to make the world a better place. So think about what you've learnt today, what else you might want to know, and how you might want to action your call to action. Thanks very much.